Data collection will be suspended until the evidence shows hospital adherence to these practices has unacceptably declined. These measures continue to be defined by the Joint Commission as measures of accountability and are currently still endorsed by the National Quality Foundation. More changes are on the horizon for 2013 and 2014. The volume of quality measures continues to grow, and there will be additional emphasis on hospital-acquired infection. Hospital-acquired infection is the leading cause of death in the United States. The CDC estimates that as many as 2 million infections are acquired each year in hospitals, resulting in approximately 90,000 deaths per year. Hospital-acquired infections not only put the patient at risk, but increase bed days, resulting in incremental health care costs. By 2014 and 2015, surgical site infection, catheter-associated UTI, C. diff, hospital provider influenza vaccination, and MRSA bacteremia will be added hospital-acquired infection measures for payment determination. I believe this table nicely outlines and summarizes the progression from CMS to hold hospitals accountable to quality-based reportable measures. It is projected that by 2013, there will be 57 reportable measures to CMS. Important to accurately reporting if a diagnosis code was acquired during the hospital stay or was pre-existing are the present on admission indicator codes. The present on admission categories have not changed for fiscal year 2012. To allow CMS to more effectively plan for future measurement requirements, CMS continues to add quality measures for outpatients. The next several slides outline the implementation dates for reporting. Beginning in 2012, there are 15 reportable measures. These include 7 clinical performance measures, 7 Medicare fee-for-service claim-based measures, and 1 web-based structural measure. Starting in August 2012, there is a proposal to include 8 additional measures, primarily related to the emergency department. The emphasis is on pain management and timeliness or responsiveness to the patient. In August of 2013, the proposal is to add surgical site infection, a safe surgery checklist, and several diabetes measures. Each year, CMS reevaluates the appropriateness of their DRG descriptions. This table provides a reference for change occurring to the major complication or comorbidity DRG classification. These are the changes effective in October of 2011. Of note, multiple open pelvic fractures is now considered an MCC. This slide represents the additions to the complication and comorbidity DRG classification. Please note the changes of deleted codes as they have impacted Accelero's classification of a few of the complication codes. Now that we have discussed the national trends for quality, I would like to discuss Accelero's support of our partners in the measurement, reporting, and improvement process of acute care complications. Each year, we evaluate the changes made by CMS and provide corresponding updates to our complication groupings. The additions denoted here should not have a significant impact on overall musculoskeletal complication rates, as they are primarily reclassifications. Last year, we made several changes to our complication groupings to keep in line with industry change. Through this process, several hospitals have further identified improvements that positively impacted the care and subsequent outcomes they are providing for their patients. No changes have been made for 2012. Through the addition of complication codes, new comparative benchmarks are now available. Our complication rate in the 90th percentile for DRG 470 has slightly increased from last year of 2.9%, and DRG's 469 comparatives have improved with better management of the patient population and CMS's transition of acute renal failure from an MCC to a CC code. This change influenced 469 positively and 470 negatively. Minimal changes occurred within the surgical spine comparative. Spine fusion except cervical, DRG 459, continues to have the highest complication rate amongst all of our surgical spine DRGs. Minimal changes occurred in our partner comparative for fracture care as well. When there are 3 DRGs in a grouping, the expectation is the lowest ranked DRG, in this case DRG 482, has no complications occurring in this patient population. In summary, CMS continues to move towards rewarding better value, outcomes, and patient care experience. It is important to clearly understand the impact of your performance metrics, as reimbursement will continue to be weighted on these results. Measures, while important in aggregate to the organization, need to be understood and improved upon by condition or by department to have an impact on your overall result.
Thank you, Michelle. The last concept that we want to cover today is a new bundled payment pilot project. About 2 months ago, the CMS Innovation Center announced the Bundled Payment for Care Improvement Initiative. The CMS Innovation Center was recently created for the purpose of piloting innovative solutions in healthcare. This bundled payment initiative is an example of one of these innovative projects. It is important to remember that CMS, as a part of the Affordable Care Act, is due to also implement an additional pilot program in the next year. Traditional healthcare payment has largely been around a fee-for-service billing that reimburses providers based upon the amount of services that they provide. In this model, there is very little incentive for providers to coordinate care, improve quality, and control cost. Bundled payment provides a single payment to a group of providers for a defined episode of care. Unlike fee-for-service payments, a bundled payment model encourages providers to work together to improve patient care coordination, quality, and also to reduce cost. Because many musculoskeletal diagnoses are procedure-driven with defined episodes of care, they have often been targeted in these bundled payment pilot projects. The objective of this bundled payment project largely mirrors the goals of the triple aim concept in healthcare, that is, to improve population health, enhance the patient experience, and reduce cost. A bundled payment initiative, if done correctly, will continuously look at improving all aspects of the triple aim philosophy. An additional objective of this project was to provide models that allowed for quicker development and adoption of evidence-based care. Unlike the ACE initiative from CMS that only had one model, the Innovation Center's Bundled Payment Initiative has 4 models. These models give applicants flexibility in the design of their bundled payment model. I will provide more detail on models 2 and 4 because they have the greatest relevance for the musculoskeletal service line. For the sake of completeness, Model 1 is an episode of care focused on the acute inpatient hospitalization and will include all DRGs. Under this model, hospitals may share gains with physicians that are beyond the predetermined DRG payment. As you can see, Model 3 is for post-acute services only. Each of these models will be 3 years, with the possibility of extending the project an additional 2 years. Model 2 is centered around specific DRGs that the hospital will define. As an example, this model could be built around primary joint replacements, DRGs 469 and 470. The definition of the episode of care is from 3 days prior to hospital admission to between 30 and 90 days post-discharge. As shown in this table, this model incorporates all of the potential post-discharge services. Depending on the post-discharge time frame, the minimum discount Medicare expects is between 2 to 3% of the current cost to care for this group of patients. It is clearly stated that CMS will give preference to those applicants that project higher discounts. Therefore, at a minimum to break even, the applicant group will need to identify at least 2 to 3% cost savings. Unlike the ACE bundled payment project, there is no prospective bid on payment. Instead, it is a retrospective reconciliation of payment based upon utilization. Model 4 is essentially a continuation of the ACE demonstration project with several exceptions. First, it allows the contracting organization to specify the DRGs to be included beyond the defined cardiac and orthopedic DRGs that were part of the ACE project. Secondly, CMS has eliminated the beneficiary cost savings component in this new model. This model is a prospective model, meaning that the group of providers would submit a bid that they would be paid on prospectively. Physicians would be paid by the hospital for their professional services, which could be at the same rate as their current fee-for-service payment or could be at another rate agreed upon between the providers and physicians. This is also different from the ACE initiative in that the physicians had no downside risk in the ACE initiative. Although each model is different, there are common threads with regard to quality indicators and gain sharing that apply to all models. For quality measures, each hospital must at least maintain or increase their CMS-defined quality indicators for a specified DRG. In addition, CMS is looking for applicants to define and measure additional quality measures that are applicable to the defined DRGs. They are also requiring physicians to participate in the physician quality reporting system as part of this overall initiative. CMS believes that physician involvement will be critical to have success in bundled payment projects. For the CMS Innovation Center models, they are waiving regulations to allow for physician gain sharing on savings that occur during the project. However, for gain sharing to occur, quality metrics must first be met and the methods must be clearly defined. If that occurs, up to an additional 50% of the physician's typical fee-for-service payment can occur as part of this gain-sharing component. This is an increase from the 25% maximum that was allowed during the ACE project. We have included the current timelines for submission of the letters of intent and completed applications. Since understanding historical data will be critical to groups who apply for these projects, CMS will provide a data set to applicants to allow them to determine baseline cost across this defined episode of care. CMS is also encouraging applicants to use this bundled payment project to reach out to other payers with the same methodology. In fact, it's stated in the application packet that CMS will look more favorably on those applicants that extend the reach of this project to payers beyond CMS. The application is very in-depth and detailed. There is a defined criteria in which the CMS Innovation Center will review and accept applicants for these projects. Even if you are not interested in participating in a bundled payment initiative, it will be helpful for you to review the application for this project for several reasons. Number one, it can serve as a great tool and guideline to determine your readiness for future projects. And secondly, it can also serve to provide further detail as to how CMS and other payers are ever more frequently approaching this expanded definition of episode of care. Doing a bundled payment project is not an easy task. Currently, we are working with several of our partners on these types of projects. It is important to recognize that there are financial risks. To maintain current margins, the savings identified and implemented must be at least as great as the discount you are offering to the payer. Even if you do not formally do a bundled payment project, the advantages of reduced variability, improved quality, and decreased cost can still occur by applying the key concepts within these models. Now is the time to really expand the definition of the episode of care and look beyond the hospital as you organize your care continuums for joint replacements, spine surgery, and hip fracture care. The next 12 months will be an exciting time as we move from defining and preparing for many of the concepts of healthcare reform to being involved in implementation. The good news is that success in this shifting payment environment centers on having capabilities in effective service line management that most of you are already implementing today. The work that you have done in creating a program infrastructure, effectively defining and improving your care and margin indicators, and the work at organizing these care continuums will help create success for your organization as these changes are implemented. Thank you for your attendance, and please do not hesitate to contact your Accelero representative for more detail or any